Okay, thanks, Tim. Yeah, so like Tim said, currently I'm doing my PhD with Dr. Jane Buxton at UBC. And Bernie Polly is actually also on my committee, but she couldn't be here today. Today I'm actually presenting on a project that I did with Jane over the past 3 years, which isn't my dissertation, but work that we worked on since 2015. Which ended just in the spring, called the Peer Engagement and Evaluation Project, or PEEP. So if I say PEEP, I'm talking about this project. Yeah, and it is really surreal to come and do this seminar, because I did a seminar, I think, 5 years ago, yes, on my work in Colorado. So it's kind of cool to see what I've been working on since then. Okay. So I'm going to be talking a lot today about peer engagement, and so I thought I'd get some terminology out of the way first, let you know what I'm talking about. So when I say the word peer, this is just an expression to refer to a person who has lived experience, who uses that experience, experience of substance use, and uses that experience to inform their professional work. And then with peer engagement, this is kind of an umbrella term to describe the meaningful involvement or participation of people who use drugs in different program and policy decision-making settings. And the word engagement and participation and involvement are kind of used all interchangeably. And I've kind of been leaning more towards the word participation than engagement, because you can engage in something, but it doesn't necessarily mean that you're going to participate or any action is actually going to happen. So they are used interchangeably, but what I'm talking about today is actually active participation. So why exactly do we do, you're laughing at Arnstein's ladder, good old Arnstein, yeah. So why do we actually do peer engagement? Why this approach? Peer engagement is a social justice oriented approach, particularly among groups who are thought to be marginalized. Peer engagement is an opportunity to promote social inclusion and comes from the stance that people have the right to be included in decisions that affect them. It stands in contrast to more top-down decision-making, and instead approaches decisions with the assumption that people and communities know what's best for themselves, especially when they're given the tools and resources that's needed in order to make those decisions. And there's been research done from a wide range of disciplines, including disability movements and mental health fields, that have shown that participation of affected communities has improves the relevance and acceptability and effectiveness of different solutions, including what priorities or interests are being served or being tackled. However, what Trudy was just laughing at is this concept of tokenism that we often talk about in participation settings, and with this goal of actually sharing power at the table and making sure that what we're doing isn't tokenistic. So tokenism happens when peer engagement isn't intended to lead to social transformation, and actually happens when professionals ask for involvement but don't enable it to actually happen or be effective. So a good example of this is when somebody invites somebody to the table, and they sit in the corner, but they don't know why they're there, they don't know how to share their voice, and they don't know how their voice is being used. And this can happen for multiple reasons. Sometimes people just don't take the process seriously. Sometimes people aren't willing to give up power. And then other times people just don't understand the commitment that it takes in order to do meaningful peer engagement. This slide just covers kind of what peer engagement with people who use drugs has looked like in Canada before our project, and kind of what sparked this project to begin with. So in 2007, there was a document called Nothing About Us Without Us, the Greater Involvement of People Who Use Drugs, a Public Health, Ethical, and Human Rights Imperative that was put out, that kind of put peer engagement on the map as this thing that we should be paying attention to. About 5 years later, there was a symposium of 14 peer-based organizations from across Canada that came together, that Bernie was actually involved with, that concluded in their report from this meeting that tokenism and lack of representation is still common across Canada. And from this, the BCHRSS committee, which you can't really see here, but it's a group of people through the BC CDC, came together and talked about this report and agreed that people who use drugs should be engaged in all aspects of harm reduction, supply distribution, program development, and decision making. But also in 2015, we did a an evaluation of peer engagement and harm reduction strategies and services, and concluded that there's really a lack of support for peer engagement, a lack of understanding, and a lack of guidance on how to do this. In 2014, I believe, a guide came out called Peerology, that was a guide on how to get involved, that was written by and for peers, but there wasn't actually anything out there for service providers on how they can do meaningful work. So that's how our project came to be. So the peer engagement and evaluation project objectives were to expand peer engagement and make it the norm in BC, to expand peer leadership and peer networks, and then to develop, implement, and evaluate peer engagement best practice guidelines for people who engage peers in harm reduction policy and program development. And I'll kind of focus on this third one today. So the PEEP project was participatory in nature. It wasn't like textbook participation, but we tried to make it as participatory as possible and to be able to kind of practice what we preached. So it was a cross-jurisdictional and remote team. So we engaged with 5 peer research assistants that represented and lived in all the 5 regional health authorities. We also engaged with several harm reduction coordinators in different health authorities, as they were going to be the knowledge users. And then obviously the academic partners, including myself and Jane and Bernie. And because we were a remote team, we mainly met via teleconference, which had its challenges, obviously. We met first just every second week, and then it ramped up to weekly because of the ongoing engagement was really important. And then when we did the bulk of our work, we would actually come together in Vancouver as a team for several days, about twice per year. The development of the protocol and the question guide was participatory. Peers recruited research participants in all of their local health authorities, and then they actually facilitated the focus groups themselves. We also did sort of a participatory data analysis. So we did a remote training around coding qualitative data, which, if anybody has done that, is very challenging. So we coded the data together, and then we came together again in Vancouver and validated the data and actually cut out all of the highlighted quotes and did Bogdan's like paste and cutting method, which you can kind of see in this middle picture here, where we actually read out all the quotes and tried to figure out which bucket it fit under and validated the themes that way. And then our knowledge translation and developing all of our tools were also participatory, which I'll talk about next. So this is one of our tools that we developed. This is a infographic kind of highlighting the focus groups and our focus group results. We created all the information on this on the telephone, which was really challenging. But actually, Jonathan, who used to work here, currently works here, did all the design for it, which was nice to work with him. But yeah, so we did, you can see up here, we did 13 focus groups across 12 different cities in British Columbia, and all the different colors represent the different health authorities. And then we talked to 83 people who use drugs in those 13 focus groups. And then over here, we have our main results. So we had 4 kind of main broad themes that came out of the qualitative, including access to harm reduction, stigma and trust, peer community, and readiness for engagement. And I'll just very briefly chat about these. So in terms of access to harm reduction, we found that people who use drugs were taking it on themselves to hand out clean supplies, and especially in remote and rural communities weren't getting supplies. So there was kind of this like unfunded, informal harm reduction network happening by peers across BC, which is really cool, but also not very good that it's not funded or supported in any way. Stigma and trust was, not surprisingly, a theme that ran through every single one of the focus groups. People said that it made it harder to get supplies and that people were being labeled and judged really often. So this was also a barrier to peer engagement, because if people were engaging and outing themselves as people who use drugs, it was actually cutting them off from health services and other things. And then in terms of peer community, this was something that was really important to our peer research assistants. they really, really thought that it was important to build peer-based organizations that empowered and built capacity for people who use drugs. And just in the last year, we found support for one of the peer research assistants to start their own peer-based organization in the north called CSUN. And she's doing that in Quesnel and Prince George. And then the final thing here is readiness for engagement. Governments and leadership need to provide resources and support for peer engagement. Otherwise, it kind of undermines peer engagement altogether and sets people up for failure. So those were the focus group findings, but how did we actually create the best practices? This image kind of goes through the inputs, the outcomes, and the activities that we did. So in year one, we did the focus groups. And from this, we developed the first draft of the best practices. We took the best practices and knew right away that we needed to get support from leadership, and we would target that first in order to get health authority leadership, which would free up resources and support for actual people that would be doing the engagement. So we did 22 convergences in just a few months, kind of this traveling roadshow, which is very reminiscent of work that I've done here at KRBC. So we did 22 convergences with people who use drugs, so 86 people who use drugs, and professionals, almost 100, including leadership, service providers, and policy task groups. And these were actually done separately rather than together, which is not what we originally planned. But the peer research assistants on the project noted that a lot of people were afraid of being outed and wouldn't necessarily come together. So this was really a step to build capacity and build support for peer engagement that would later continue with more conversation and engagement. So yes, we went back to the communities. We shared the focus group results. We took the first version of the best practices back. We gained a lot of support from leadership, which was kind of ramping up in 2016. And also during that time, we evaluated the first version of the best practices. So we asked people about their knowledge of peer engagement, if they supported it, and also what they thought about our different tools. And then we also received feedback from peers, peer-based organizations, and health authorities, and practiced a ton of reflexivity during this entire time. We were running a peer engagement project ourselves, and so obviously we were learning a lot and feeding that back in and collecting data through our minutes and just learning a lot. So with that, we took all this information that we gained in 2016 and put it back into the best practices and came up with the second version, which I'll present today, along with some other tools that I'll talk about. So this is kind of like the main star of our show today. These are the peer engagement best principles and best practices, and I don't actually have a copy, unfortunately, because they're kind of hot off the shelf and we've completely ran out of them. But they are available to download on towardtheheart.com. And if you have a hard time navigating this website because it's not very accessible, just shoot me an email and I'll send you a copy. So this is actually a 50-page document that is, we got feedback from the first version that the 50 pages isn't that accessible. So we created actually a 4-page kind of grab and go, which is very straight to the point. So these are kind of some examples of the principles and kind of a checklist of what to do. And the principle or the documents organized into the first half is kind of the principles, so the why, which will really gain support. And then the second part is the how, which is divided into 4 different sections, including before committing to a peer engagement project at all, like whether you can even do it, then before engaging with peers and what to be mindful of, engagement itself, and then disengagement when you actually end the participation. These were some other tools that also came out of the project that I think are equally as important. So this first one here, we have 2 versions of this as well. It came out of a working group that Jane and I started in the middle of the project on paying peers in peer-based work, which was a huge challenge for us as we navigated different institutional financial processes and structural barriers and all types of challenging things. So we came up with a group with different people from across BC that work with peers and talked about their experiences, and then came up with this guide. This actually spun off to be a smaller research project at the CDC, and with a couple girls that then created peer payment standards for short-term engagements at the CDC, which are also available on the website, which are really great. They did kind of similar just focus groups with people who use drugs to ask them how they wanted to be paid. The other thing that we created is this Language Matters infographic and these modules, which were to really address the theme of stigma that we heard in the focus groups. So this obviously talks about guidelines for using non-stigmatizing language when you're working with people who use drugs. And then these are a set of modules called the Compassion Engagement modules that are a series of interactive case studies that are photos that we took with our team. And then there's quotes from the focus groups overlaid. And it's kind of set up as like theater of the oppressed, where you negotiate kind of how a scene should look and how to change things. And the modules are designed to engage people who use drugs and people that provide services to them. So it really works best when it's co-facilitated and people can work together. And then this last one here is just how to involve people who use drugs. This is a resource through the BC CDC that our team helped develop and rework. That's just for short-term engagements, and it's a 2-pager that's also in the best practices. Some other work that we did, more academic-y. We've done 17 presentations. I couldn't believe this when I looked it up yesterday. 17 presentations just at conferences, but it just doesn't include things like this. If you include things like this, I think it's like we've done an additional probably 30. And they're mostly participatory. So whenever we could, we would bring other people from our team or send other people from our team to go to these conferences. And then we have several publications out, which took a back burner in this work, as it usually does, because this information doesn't necessarily have any impact for the community. It's mainly for academic impact. So yeah, this will be coming out. And then this last slide, I just wanted to talk about a couple of takeaways from our work. So this project was very timely. Before we started the project, we didn't have the overdose crisis across BC. And so it's very timely. There's the response to the overdose crisis has been largely peer-informed and peer-led, as we can see with all the overdose prevention sites across the province. Meaning that as we were doing this work, people wanted to know how to do participatory work and were like knocking on our door being like, when are the guidelines ready? When are the guidelines ready? Which was really exciting. And we've handed out, like we printed 300 guides to start with and they were gone instantly. And people have been coming up to me like at my office and things and like, have you seen these guidelines? Actually. So that's been really cool. But however, it's also highlighted some of these other takeaways. So it dawned on us kind of halfway through, and actually one of our peer research assistants highlighted this, that as peer engagement has been taken up more and more, we were wondering if the current systems in BC aren't actually fit for meaningful peer engagement. So whether there was actually enough resources and support to do this work, because we were noticing that people were really doing peer engagement off the sides of their desk, which was promoting kind of a model of tokenism. The other thing is, by having this set of guidelines, were we promoting a top-down process now that professionals, quote unquote professionals, had this set of guidelines and they now had power over the process and could say, well, I know what's best now, I have these guidelines. So we were worried that, or still am worried that we might be promoting a process that isn't collaboratively built, even though it says that in the guidelines, but is one that just gets taken over by professionals. And if we are promoting a model of tokenism, we might actually be reinforcing stigma and exclusion and disempowerment if people are getting invited to tables and just sitting in the corner the whole time. And then finally, probably the biggest lesson from this work is that this work is really hard. And people don't realize that going into it, myself included. Doing participation is a lot different than thinking about and planning participation. It's a lot of time, very, very time intensive and emotionally intensive.
Yeah.
Took the words out of my mouth. I continue to learn every day. And even though people's intentions might be good, having this set of guidelines doesn't mean that we need to stop practicing reflexivity. One of my favorite quotes from this whole project was about 6 months ago. Somebody said to me, if you think you're doing participation right, you probably aren't. So as soon as you think you got it, you totally don't. So it's constant grappling, and I think it'll be this kind of career-long grappling that happens. And then in terms of future work, we have a couple spin-off things happening. So Bernie and Jane have funding to do this grant on peer-to-peer support. So they're working with Rain City and Solid Outreach to look at different peer-developed support models for peer-based work, which is really exciting. I think Lindsay Shaw is the student on that. And then my own work, I really took up the issue of oppressive peer work and pay conditions. And I'm looking at the burnout and stress and exploitative nature of peer work and how people aren't paid for their time. So I've collected all my data for that, and I've analyzed it, and I'm hoping to publish it all this year. And I just wanted to acknowledge the amazing team, which was quite large, and our partners and our funding. And that's it.